Hello everyone, good afternoon and welcome to this webinar on TTP diagnosis. So let me introduce our speakers for today. Firstly, we have Dr. Matthew Stubbs, Haematology Consultant at the UCLH TTP Specialist Centre. Next, we have Deepak Singh. He's a Hemostasis Laboratory Manager and ADAMS TS13 Testing Service Lead at HSL. And also from the lab, we have Sabina McCann, a Senior Biomedical Scientist. So I'll hand over to Matthew to start the session for us.
So our presentation today is on TTP diagnostics, preventing a fragmented approach, really trying to help with the diagnosis and treatment of TTP. So the presentation today is broken down into three components, which will each be presented by one of the different speakers. So I'll be taking us through the first part of the presentation, part one, talking about the clinical diagnosis of TTP. So I'll start by talking about some of the differential diagnosis and investigations when thrombocytopenia is identified in the laboratory, and then the definitions for thrombotic microangiopathy and MAHA. I'll then talk about an introduction to TTP and the pathophysiology of the disease. And going on from that, I'll talk about the clinical assessment of TTP, the specific treatments that are required for that and the monitoring, and then talk about an update from the TTP specialist centres in England. Following on from that, I'll hand over to Deepak, who will talk us through ADAMS TS13 testing, going through the different different ways of requesting ADAMS 13, the pathways, and the different platforms that are available. We'll then talk a little bit about the interpretation of ADAMS 13 results and some of the limitations of the laboratory assays. We'll then talk about how some erroneous results can be identified and how potentially these can be corrected in the laboratory. Finally, for our third part of the session, which is interactive, I'll be handing over to Sabina, who will talk us through some case studies, some question and answers, and then we'll have opinions and discussions. So thank you for listening today. I'll talk first about thrombocytopenia. So as many of you will be aware, working in the haematology laboratories, thrombocytopenia is a common issue that's identified within the haematology laboratories. And high up on the differentials to consider when a patient has thrombocytopenia is TTP. So as per the laboratory SOPs within your lab, a newly identified thrombocytopenia that's not explained should be prompting the review of an urgent blood film. And this is important to try and consider the differential diagnoses that a new thrombocytopenia could be related to, of which TTP is on that list. Important parameters that make us particularly concerned about TTP if there is evidence of microangiopathic hemolytic anemia, and we'll talk about that over the coming slides, in addition to the thrombocytopenia that we have identified. And those cases should be being referred to your hematologist. Some important different differentials that can be supported by review of the blood film. So in a patient with ITP, you would expect there to be a thrombocytopenia, but no evidence of a MAHA. Similarly, a patient might have DIC with thrombocytopenia, and those patients will, again, typically not have MAHA features, although they may have some, but will often have a coagulopathy, such as prolonged coagulation screen and low fibrinogen. It's also possible the thrombocytopenia may not be related to hemostasis at all. It may be a hematological malignancy, such as a new leukemia or other bone marrow infiltrative disorders. In addition, other potential causes may cause the thrombocytopenia that might not be immediately apparent in the laboratory and will require clinical correlation, such as reactive processes, infective processes, and drugs. So when we talk about MAHA and TMA, I'm just going to talk about what these different terms mean. So a microangiopathic hemolytic anemia is a process where there is fragmentation of the red cells leading to polychromasia and these typical features that we would see on the blood film here. So fragmented red cells and polychromasia as identified in this image on the right hand side. We would say somebody has a TMA when that is combined with a thrombocytopenia, so a MAHA and thrombocytopenia. And a TMA is an umbrella term that can be caused by many different conditions, of which TTP is one of those conditions with a low ADAMS 13. So on our next slide, I'll talk about some of the conditions that can give us MAHA and TMA type features. So as I mentioned, TMA is an umbrella term, and lots of different conditions can present with these features of MAHA and thrombocytopenia, of which I've highlighted TTP in red on the left-hand side. But there are other conditions that can cause this, such as hemolytic uremic syndrome. Cancer, particularly metastatic cancer, can be associated with TMA, various autoimmune diseases, vasculitis, some pregnancy conditions such as preeclampsia, HELP, infections and sepsis, malignant hypertension and DIC. So those are other things that potentially could give us these features of thrombotic microangiopathy. But when we focus back on TTP, just at this point, I'll highlight that there are two main subtypes of TTP. Immune TTP, which is an autoimmune process driven by autoantibodies, and secondly, a genetic form, hereditary TTP. And we'll talk about those again over the coming slides with the pathophysiology and how these are different. So if we take a step back and think, why are we interested in TTP and why is this important? There are some important points here, and this is the British Society of Haematology updated guidelines on diagnosis and management of TTP. So TTP is a very rare disease. It's an ultra rare disease, and as I mentioned, it can be either autoimmune, immune mediated, or genetic, congenital. The reason why it's important is TTP is a medical emergency. And so that's why it's important that we identify these cases both from a clinical perspective and also from a laboratory. Clues that can suggest that a patient might have TTP separate from the laboratory features are neurological involvement. So if you have in the blood film or request forms that the patient has neurological symptoms, stroke, TIA, headaches, visual disturbances, those could be additional clues that the patient might have TTP. And the reason why this is so important and why it should be both promptly investigated by a blood film and discussion with the haematologist is that the emergency treatment is life-saving for these patients. So without prompt and appropriate treatment, there's high rates of mortality in TTP patients. But fortunately, with appropriate investigation and management, particularly with plasma exchange, current mortality rates in the modern era are very low with appropriate treatment. So just going to talk a little bit now about what's going on from a pathophysiological perspective in TTP. So this top panel here shows us what's happening in normal blood clotting. So the endothelium shown in yellow, the blood shown in red, and then the different key molecules shown here. So in the black lines represent von Willebrand factor, which is secreted from the endothelium and an important molecule for normal blood clotting. You may have heard of deficiencies in von Willebrand factor being associated with von Willebrand disease, but really we're looking at it in a different perspective here today. So von Willebrand factor is crucial for normal blood clotting, but equally we don't want von Willebrand levels to be too high, and it's the role of ADAMTS13 to cleave von Willebrand factor to prevent the buildup of ultra-large VWF. What happens in TTP, both immune and congenital TTP, is there's a deficiency in ADAMTS13, either driven by an autoimmune process in immune TTP or a genetic variant and genetic deficiency in congenital TTP. And what this leads to is buildup of ultra-large VWF multimers, which are highly prothrombotic, and this leads to the accumulation of platelet-rich microthrombi, which cause the resulting multi-organ involvement that we see in TTP. I mentioned it's important to consider TTP from a clinical perspective, and historically TTP was described as a pentad of symptoms shown here: thrombocytopenia, MAHA, fever, neurological involvement and renal involvement. But we know that many patients don't have all 5 of these symptoms, and actually TTP should be being considered when patients have just a MAHA and thrombocytopenia. I mentioned earlier, and I'll reiterate, it's important to consider and suspect TTP if there's unexplained thrombocytopenia in the presence of neurological symptoms, particularly stroke, TIA, visual symptoms, and low GCS. And this should be a clue in the laboratory if this is included on the blood request form that these features are present in the patient. That would point a strong suspicion towards TTP, and these can be considered. Patients may equally present with other features such as bleeding, bruising, fatigue, and lethargy or confusion. So when we're trying to make the diagnosis of TTP, it's really important that there's robust clinical information about the patient with the history. And as I mentioned in the beginning slide, there are many different conditions that can mimic TTP and present with the TMA. And so this can be useful information that may or may not be included on the laboratory request form to explain the features that we're seeing in the laboratory. Things such as DIC, coagulopathy, liver disease, metastatic malignancy, valvular cardiac disease, renal replacement disease, and prior autoimmune disease. Just to mention specifically on autoimmune disease, it may be that the previous autoimmune disease is causing the disease process, but it's also possible that the patient with a history of autoimmune disease may have developed TTP as an autoimmune phenomenon. So that's important clinical information to have available. So when we're trying to make the diagnosis of TTP, in addition to the history and examination that we've already mentioned, it's really important to combine this with the laboratory testing. And this is where the hematology laboratory is absolutely central and pivotal to suspecting the diagnosis of TTP. The routine testing within a hematology laboratory will give us clues as to the suspected TTP diagnosis, such as thrombocytopenia and MAHA. And other routine parameters that should be available to suspect the diagnosis include the hemolytic markers, such as raised LDH, raised reticulocyte count, and raised bilirubin. But in addition to the blood film, those features can support the diagnosis of TMA. And I would recommend that those cases particularly are being referred urgently to your local hematologist for consideration of the TTP diagnosis. Following this, patient should be being referred to a TTP specialist centre as appropriate, and I'll talk about that over the coming slides. But now all patients with suspected TTP in England should be being discussed with your local regional specialist TTP centre. So I've talked a little bit about TTP being a medical emergency, but how should that be being happen? So once TTP is suspected, an appropriate referral should take place so that prompt treatment can be undertaken. And these patients are recommended to receive plasma exchange urgently within 4 to 8 hours of the referral time. So there are 4 main pillars of TTP therapy in the emergency setting. So plasma exchange, which really is used as a source of ADAMTS13 to replace the deficiency in the ADAMTS13. In addition to that, in immune TTP, steroids and rituximab are used as immune modulatory treatments. And then the specialist treatment of capivasertib, which is a monoclonal nanobody targeting von Willebrand factor to help break the pathophysiological chain that we see in TTP. And those treatments lead to a improvement in the clinical condition of the patients. Following on from the emergency management of TTP, all patients with TTP are monitored as an outpatient to try and prevent relapse of their TTP. And this schema here shows us what is happening in a typical TTP patient's course. So in the left-hand side, we can see at time point 0, patients have a low ADAMTS13 shown in red and a low platelet count shown in blue. But after the introduction of the 4 main treatments, rituximab, steroids, plasma exchange, and capivasertib, we'd expect firstly a brisk improvement in the platelet count, and following on from this, a normalization of the ADAMTS13 activity. All patients are recommended to have monitoring of both their platelet count and ADAMTS13, and around half of our patients will have a subclinical fall in their ADAMTS13. This is really important, as if we identify the fall in the ADAMTS13 before the patient develops clinical symptoms, then it's possible for us to treat these patients electively, typically with anti-CD20 therapy such as rituximab, and in that process we can prevent the patient from having another acute episode of TTP and the resulting morbidity and mortality that can be associated with this. So just to end on here, so England has now become the first nationally commissioned TTP service across the world. And here this figure shows us the 9 different regional TTP specialist centres over 11 different sites. And your local hospital should be discussing suspected TTP cases with your local regional TTP specialist centre. So just to reiterate, that should be being considered in patients with MAHA and thrombocytopenia to consider a diagnosis of TTP. If the laboratory features are suggestive of this, then we'd recommend urgent discussion with your local haematology team and an urgent blood film to try and decide whether the patient does have TTP. So I'd like to thank everybody for listening to my portion of the slides today, particularly referring sites, laboratories, our ambulance service, emergency and critical care team, in addition to both the local TTP team, the TTP network group and registry here. So at this point, I will hand over to Deepak to take us through part 2 of the presentation.
Okay, thanks, Matt. So I'll be talking to you about ADAMS 13 testing. I'll be focusing on the activity levels in ITTP presentations. So a little bit more on the ADAMS 13 function, more focus on the lab side. So the ADAMS 13 principal function is to cleave VWF at the A2 region to make it into less active forms. Now, the A2 region has 73 amino acids, so the reagents that we use to detect ADAMS 13 activity is denoted with VWF 73. So that's where that terminology comes from. If the ADAMS 13 does not cleave this VWF, this leads to the string-like a large VWF accumulation, and this spontaneously interacts with the platelets. So this is what causes the thrombocytopenia and the resulting microthrombosis that is developed is then clogging up major organs, which is causing the organ failure and the subsequent red cell fragmentation, which is what causes the normocytic normochromic anemia. Now, the deficiencies are caused in numerous conditions. We are focusing on the immune TTP. It sometimes is called the acquired TTP. This is caused by IgG antibodies. It's either inhibitory or non-inhibitory. The inhibitory antibodies is basically an antibody that binds to the active site of ADAMS 13, which prevents its ability to bind to the A2 region of VWF. And the non-inhibitory antibodies is another type of antibody that binds to the ADAMS 13, changes its configuration, and it's hence cleared out more readily. We have congenital TTP, where the ADAMS 13's production is impaired, and we see deficiencies in other TMAs, especially when there's endothelial damage, like in HUS, where there's a higher release of VWF, which consumes the ADAMS 13 in circulation. And we're also seeing this in thrombotic disorders now, especially arterial thrombosis. And again, this is relative to the amount of VWF antigen levels. So the ones in gray here, we will deep dive in later talks and discuss this in more detail. We'll discuss more in detail about the structure as well of ADAMS 13, because this is quite intriguing. But for this tutorial, we'll just talk about two other key factors, which is that the ADAMS 13 requires zinc and calcium for its proper activity levels. And more importantly, that ADAMS 13 has a long half-life in circulation, which means that it is also stable in the test tube. This is relevant because if you miss ADAMS 13 testing, say overnight, hopefully you won't after this talk, but if you do, that sample is still viable for testing. And it's usually that first presentation sample that is what is required for correct diagnosis. So yeah, the focus today is ADAMS 13 on TTP diagnosis. The monitoring bit we'll cover later. So why do we use ADAMS 13 in TTP? And you can see by this graphic here that TTP Adams 13 is significantly lower than the other TMAs that we encounter. Now, this level that we call significant is actually less than 10%. That's in the BCH guidelines. ISTH is also 10%, but they have a 10 to 20 equivocal area. Congenital cases can be higher, and method-specific cutoffs are currently being evaluated, and this will be quite interesting. TTP relapses post-acute phase, that is, this is around the 15 to 20 mark. So in isolation, when you read about it, less than 10 sounds straightforward, but when you put all the literature out there and combine it, it does get a little bit confusing. So we'll be looking at how to make this a little bit clearer to understand in clinical context. So a little bit about the testing methodologies that are available. We have the FRET methods. There's an ELISA method, and there's a chemiluminescence method that's widely available. We locally have all the platforms available, and we've used that in various studies and clinical researches. But for TTP diagnosis and monitoring and treatment efficacy, we're using only the FRETS method. For those that don't know what the FRET stands for, that is the fluorescence resonance energy transfer method. So this is for the pure scientists out there. But essentially, it incorporates physics, chemistry, and biology in its methodology. And in context for Adams 13 testing, it was developed about 20 years ago by this Japanese scientist, Koichi Kokumani. And since then, it's been used quite widely, or the method's been adapted quite widely in diagnosis of TTP. And not only that, now there's a lot of data out there on its monitoring, etc., using this method. So it's at the moment regarded as the gold standard, as all the data regarding publications usually comes from this method. Sevron has automated this this method, and that's provided by Techniclone. And QStar by Werfen is also automated, and they're using a chemiluminescence method, which is also an interesting method. I believe Sysmex are also released a chemiluminescence method, which is under evaluation at the moment. And this is just an illustration of the different types of methodologies that are employed by the different methods available at the moment. The FRETS is a one stage, and the other methods are 2 stages. But apart from that, I won't go into detail with the specifics on it in this talk, but I just wanted to illustrate how different they are. But regardless of these differences, we are still using the cutoff of 10%, which is okay, because in generally most results for ITTP at presentation is usually less than 5%. And in fact, it'll be much lower if we used if we were using an automated method. Currently, we're using the FRET and ELISA method, which is a manual method, and we usually have a cutoff at 5%. We won't talk about the congenital because this will be even more complicated going forward. We can get really higher results on this also, and this is going to be confusing for this talk. But what I will mention is the gray zones, or what I like to call the fun zones. Here you have results that are around the 2 to 12 mark. And this is when you start thinking, is it actually TTP or not TTP, or is this just statistical variation? Interestingly, in the chemiluminescence method, there is no results that populate into that 2 to 10 zone, which was something that we were quite impressed by it. And initially we thought this was a good thing, but unfortunately what has happened is we are starting to get some discrepant results that's been widely reported now that are falling between that 2 to 10 mark that is not actually TTP. So we presented this paper a few years ago where there were critically unwell patients with thrombocytopenia, red cell fragmentation, no signs of a DIC at the time, but they had results suggesting of TTP, which made it quite confusing. And this is just a snippet from that paper that we published. So there is a lot of work still to do on a method-specific cutoff. And I know there's a few sites that are working on this at the moment, including ourselves. So hopefully that'll be cleared up in the near future. Okay, so these are some of the solutions we have at the moment, and these are the common factors that we see currently. Raised bilirubin is one of them. High bilirubin can cause interference with the FRAT assay. This sounds a little bit paradoxical because you're supposed to get high bilirubin in hemolysis, but if it's a certain level, really high, then that can interfere with the FRAT assay, falsely reducing the levels. Simple dilution does fix that problem, but we do need to know the bilirubin count before we start the FRAT assay. EDTA contamination seems to occur more frequently than I had initially anticipated, but because ADAMS13 activity requires zinc for normal functioning, even a little amount of EDTA can really impact the ADAMS13 activity levels, and it usually grounds it to near zero. So this is why we also suggest using serum as a backup in case you get a falsely low ADAMS13 result. And if you're ever unsure, you can ask your chemistry colleagues to run a potassium level for you offline for that sample. Sepsis we talked about with the chemiluminescence method. It's loosely called sepsis because most of them are sepsis related. Now, what we get asked a lot is, why is sepsis requested for TTP differentiation? And there's two good answers for that. Sepsis is usually not evident at the time of presentation, and there can be a lot of overlap in terms of these conditions. So if you have a TMA, you should do ADAMS13 testing, but if you suspect sepsis, you shouldn't use the chemiluminescence method at this current stages. Congenitals is also something that we'll have to pick up later. This is actually, we're waiting for a publication which is done by our next speaker actually, which is having a close look at the all the methods, in fact, for congenital cases. I suspect that we will have to do a lot more ADAMS13 antibody levels to exclude congenitals and perform genetics because there is a lot of variability on levels on these cases. So in terms of now reporting, now that we know the limitations of some of the assays, the importance of clinical correlation is really important, and we do this with other assays in specialist testing. Clinical correlation is not restricted to clinicians. Laboratory staff, especially specialist BMSs, should be looking at the clinical details where it's available, and if it's not, just response to treatment is another good way of keeping in tabs with a clinical correlation. Where BMSs can be more useful is using or excluding the secondary causes like DIC, HIV, B12 deficiency and antiphospholipid syndromes, etc. Because some of these results at the time of reporting might not be fully released, and having that available or looked at it and then discussing with your consultant before you release it is a step in the right direction. Data review is something that I'll talk about next, but I think this is probably more essential and mandatory that should be in place. And this is looking at different levels of platelet counts and other basic parameters before you release the result. But overall, you need some sort of protocol that is in place before you report the results, whether it's just asking the clinician that does this match your clinical clinical picture, or having a repeat criteria if something fails or something is abnormal. Now, just a caveat uh, before we move on is that if you are repeating a sample, ensure that the repeat sample is a pre-exchange sample, and this is also having the citrate sample as a backup sample is serum sample as a backup sample in these cases is a good option, because if you've used the citrate sample and you want to repeat it, you've got the serum sample to do the repeat testing. So data correlation. So this is something that I use for training, and it's a good way to kind of integrate your chemistry results. So if you look at creatine in HUS, whether it's atypical, which is complemented mediated, or STEC HUS, which is bacterial mediated, the creatine levels are usually much higher than in TTP, and this is because in these conditions, it is your own immune system that actually infiltrates the glomeruli, worsening the renal function. So this is a good indicator whether it's HUS or TTP. And the other one is platelet count. In TTP, platelet counts are usually much lower than in HUS. It's usually less than 30. But please remember, this is just a rule of thumb. It only occurs in about 70% of cases. You do get an overlap sometimes of these markers. The other good one to look at is LDH, which I want to talk about, because as your red cell breaks, you release LDH. And if this LDH is 2 times upper the normal limit of your reference range, and particularly if it continues to rise, this is likely to be a TTP, considering if you have the or other markers supporting it also. And just a note for the chemistry team, please note this is in TMA, this is in vitro hemolysis. This is not in hetero hemolysis, and this should be reported. So if we look at how this looks in a clinical picture, just as an example, so if you get a TMA, which is confirmed red cell fragmentation, genuine red cell fragmentation with thrombocytopenia, and you get a borderline results or results that you think is not in keeping with ADAMS13, and you start thinking, is this TTP or unlikely to be TTP? And then you'll start looking at some results. You'll have a lot of results coming through. This is just an example. And the first things you kind of gaze upon is your coagulation screen. And if this is raised, then you start thinking, is this likely to be TTP or not likely to be TTP? And the answer would be, because TTP is a primary hemostasis defect, it's unlikely to be TTP. And also the raised CRP is pointing towards an infection type condition. So the answer here would be that it's unlikely to be TTP, and you would exercise some sort of repeat criteria before you moved on. And conversely, if you had a low platelet count with sharply rising LDH, is this likely to be TTP or unlikely to be TTP? Even if you have borderline results, the answer would be that it's most likely to be TTP. Okay, so this is an example of how you can use, just common markers in cooperation with your ADAMS 13 to make the right decision. ADAMS 13 requesting and pathways. So this is a common question by most people that are referring. So the first thing we need to do is if there's clinical suspicion of TMA. So basically, anytime there's a TMA, ADAMS 13 should be tested. But the key question here is it urgent or is it non-urgent? So urgent is something that we think that is probably likely to be TTP, as Dr. Stubbs suggested that the medical treatment is very effective now. So if it is TTP, we want to put them into the right treatment as soon as possible. And if the patient's deteriorating also for unknown reasons, then the testing becomes urgent. Non-urgent requests are usually if it's a TMA, but we think we know what the cause could be. It could be malignancy, it could be some other underlying condition, B12 folate, for example. So these become non-urgent, but we are still testing just to exclude it. A concurrent TTP, for example. So, okay, when the decision's been made that testing needs to be done, the blood needs to be sent with a request form. Now, hopefully, you'll appreciate that the parameters that we are using is vital for our final diagnosis. So things like LDH, platelet count, etc., is very important to us. So if you can include that in the request form, that will help the specialist laboratories for sure. Also, if there's a payment to be made and couriers to be arranged, these should be arranged by the lab. It's not fair for a consultant to be dealing with it when they're dealing with a very sick patient, to be dealing with this administrative type duties. And also, when the report is done with the compliance with GDPR, we can only report back to whatever's been stated on the request form. Now, all of these factors can be sorted out if you have a SLA or service level agreement with your referring laboratory. And I think this is a part of ISO 15189 requirements, and it has been readily checked. So it's good to have that in place to streamline your referral processes. Okay, just to conclude, we'll conclude by stating that this is one of those tests that requires get it right first time incentives. And I was listening to a get it right first time talk by NHS director of pathology for this incentive, and I couldn't stop thinking about how this involves TTP. I think and everyone involved here could make a difference in their laboratories to make this a more streamlined process by taking a few simple steps. So referral sites, reporting the blood film stats in all TTP cases 24/7 is, I think, imperative. Getting a competent staff member to do it also to make sure that they pick out the genuine fragments and don't mistake it for other types of fragmentation, like Burr cells, for example. Chemistry and other supporting teams, to report the LDHs and other tests is also vitally important to the referring lab. Having an SLA set up with your referral sites, and if you are using couriers, please make sure that they are direct couriers. And also the relevant information required. So when you are referring, listing the bilirubin results, platelet count, LDH levels, and things like that, or any other underlying clinical information is so vital in the overall interpretation of TTP. And just to note that this is, this is not just isolated to special hemostasis. There's the hematology people involved, the morphologists involved, your routine coagulation team, microbiology, chemistry, your referral department. There's so many people involved in this process. So this is a genuine team effort to get it right. And for the specialist centers, we'll be having additional talks about this, but, getting the platform or knowing their limitations, the repeat criteria, and correlation with clinical findings are all things that we should standardize and do uniformly. And cross-training is another thing, especially with your phlebotomists, your registrars that you'll be collaborating with, your chemistry teams, etc., is a really good incentive to get implemented in your teams. Okay, thank you very much. This was my talk. Thank you very much.
Thanks, Deepak. Hi, everyone. So this is now the interactive part of our talk today. I'll be going through 3 case studies and there will be some interactive polls. The polls is part of the Teams app. If the poll does appear and block your view of the slide, please just close it and you can answer the poll in the chat. So, case study 1, a brief background. This is a 56-year-old male. He's post-op following a TURP procedure at a local district general. So a TURP procedure is to remove part of the prostate. He has some previous medical conditions of diabetes and high cholesterol. However, post-op, the clinical team have noted that he had somewhat of a muddled mind. So at this point, I would like to launch the first poll. So drawing on information that Matt and Deepak have already spoken about and the clinical presentation of his patient, hopefully everyone can see the launch. Which of the following information provided could be a symptom of TTP? The fact that he's diabetic, he's a male, the muddled mind, high cholesterol, or if you're unsure, please just select that option. I'll give everyone around 15 seconds to just discuss it with your peers, and then we'll talk about the answer. I feel like I should play the countdown conundrum to give everyone a bit of a warning. Okay, so there's a few responses. I'm going to close the poll now. So the correct answer is muddled mind. As Matt spoke about earlier, neurological impairment is quite a clinical feature of TTP. So as this was a post-op patient, there was the opportunity to see some pre-op bloods done in January. This patient had a hemoglobin of 108 grams per litre and platelet count of 432. Following his procedure, the team sent some post-op bloods. The normal ranges are indicated under each parameter. His HB has now dropped to 62. His platelet count has plummeted to 7. His creatinine is 97, with a troponin of 97 also. More interestingly, the LDH has now been reported as hemolyzed. As Deepak has said, LDH is also a good clinical indicator for TTP, and the clinicians do use it in their differential of diagnosis. I will leave these results on the screen as I now launch my next poll. I would just like to say I'd encourage all staff grades that you're with, from MLAs to BMSs, to just consider their role in these results if they see them. So, given these results, what action would you take in response? Confirm sample ID, clot check sample and rerun, inform requesting clinician and suggest repeat, make and review an urgent blood film, refer the blood film to the haematology SPR, action all of the above in an urgent manner, or if you're unsure again, please just select the answer. Sorry, there's a question there about normal ranges. Normal ranges are under the parameters. Hopefully you're able to see the screen. So it's really encouraging to see that everyone has actioned all of the above urgently. I'm not sure of the percentage of the participants here today are working in hematology lab, but from me, when I've worked in hematology, I know that MLAs to the BMS authorizing to the BMS reviewing the blood film all have an equal role in the positive outcome of these type of cases. So following on from this, a repeat FBC sample was sent with additional testing. So again, the hemoglobin came back at 62, the platelets are at 8, and the reticulocyte count is 6.9%, so that is raised. A coagulation screen was sent, and all of those parameters are normal. Your creatinine has slightly increased to 103, and troponin is now 120. Secondary hemostasis has not been affected, as we can see from the coag screen. Another urgent blood film was made for review, and the hematology SPR then immediately contacted the UCLH TTP Specialist Centre for a case review. We want to highlight that the fast action of the laboratory staff in making and reviewing the blood film attributed to saving this patient. Here I have a snip of blood film. I've highlighted 3 main features: schistocytes and the red cell fragments in red, polychromasia in purple, and as you can see, there is clear thrombocytopenia. The next poll is now ready for us. What are the main blood film morphology features indicative of TTP? Select all that apply. There's a few options here: polychromasia, spherocytes, burst cells, schistocytes, platelet clumps, thrombocytopenia, or if you're unsure, please select all that you feel are most indicative of TTP. So we've had a good 70 responses to that question. So the main 3 that I've highlighted on this blood film are key features of TTP, but obviously each case is slightly different. So the patient was immediately transferred to UCLH for immediate treatment with plasma exchange, as Dr. Stubbs discussed earlier. At this point, UCLH took their own bloods. The hemoglobin was now 58, a platelet count of 7, Ritix slightly increased to 7.15, again a normal clotting screen. The creatinine was 103, troponin had doubled since it was last taken at 207, and most interestingly, the LDH has now been reported as 1,996, which is 9 times the upper level of the normal range. The ADAMS-13 activity came back as less than 5 international units per deciliter, with our normal local reference range between 60 to 146, so thus confirming TTP diagnosis. And the ADAMS-13 antibody was 51%, normal range less than 6%, and therefore we have confirmed that this patient is in fact immune TTP. Although there was a swift action from both UCLH and the local district hospital, the patient deteriorated in the blue light to UCLH. There was cardiac impairment from the organ ischemia caused by microthrombi, and unfortunately the patient had to be intubated and ventilated while being treatment with plasma exchange, steroids, Kaplan and rituximab. However, I'm very pleased to report that the patient has since made a full recovery and is attending his follow-up appointments. So on to case study number 2, a brief background again for this patient. It's a 36-year-old male who presented to his local A&E as a query stroke call via an ambulance. There was no previous medical conditions noted. However, his family that attended with him have reported a 2-day history of clumsiness and unable to form words correctly. So the local A&E team sent the patient for a CT scan, and this has confirmed an acute stroke. Bloods were also taken upon admission to A&E, with the hemoglobin coming back as 138 and a platelet count of 49. At this point, I'd like to launch the next poll. From the indicators given from the information already given, which indicators query a TTP diagnosis? Please select all that apply. So a stroke, thrombocytopenia, the neurological impairment, or if you're unsure. had a good response to that question. The confirmation of stroke, thrombocytopenia, and the reported neurological impairment combined are very concerning features to query a potential TTP diagnosis. So everyone got a good spread of the results. Again, there was a clotting screen done, and that was normal. So the clinical team sent repeat bloods to confirm the thrombocytopenia, but the clinical team then queried as to why a fit and previously healthy 36-year-old has had a stroke. Due to the thrombocytopenia, a blood film was made and reviewed urgently. There was red cell fragments present on the film, and this alerted the stroke team to contact the local haematology team, and they contacted the UCLH Specialist Centre for a case review. The patient was accepted to UCLH care due to the high probability of a TTP diagnosis and to begin immediate treatment with plasma exchange while ADAMS13 activity testing to confirm. Upon admission to UCLH, we have further results. HB was 97, platelets had dropped to 32, Ritix was within normal range of 1.36, again at normal clotting screen. Creatinine was 113, troponin raised at 70, and an LDH was now 2.5 times the normal range at 527. The ADAMS activity confirmed as less than 5 international units per deciliter, and the ADAMS antibody is present, which confirms immune TTP again. So the swift action of the lab allowed for the patient to be blue lighted to UCLH for the treatment to begin with PECs, and following stroke rehabilitation, the patient has also made a full recovery. So this is our final case study number 3. This is a 27-year-old female. She is pregnant at 37 plus 5 weeks gestation, and she's turned up to her antenatal clinic because she has severe itching. So at this antenatal appointment for the bloods that were taken in August, her hemoglobin was 108 and a platelet count of 156. 2 weeks later, the patient was recalled due to deranged LFTs following these bloods in August. Unfortunately, I don't have access to biochemistry results, but I do have the hemoglobin, platelets, and reticulocytes, which were all, hemoglobin and platelets slightly lower than normal range. However, her coagulation screen was grossly abnormal. She had a prolonged PT at 30.5 seconds, APTT 73.2, and fibrinogen was less than 0.5. So these results were confirmed. 2 days later, following a fibrinogen concentrate infusion, the patient had to undergo an emergency C-section. Post-surgery, the patient had bloods taken again with a hemoglobin of 86 and a dramatic drop in platelets to 25. Her coagulation screen again was abnormal for the PT and APTT at 15.1 and 88.5 respectively. However, the fibrinogen was just within normal range due to the concentrate. At this point, the clinical team also did a D-dimer, which came back as 14,222, which is grossly abnormal as the local normal range was less than 400. Again, repeat bloods were sent due to the drop in platelet count. Due to thrombocytopenia, the BMS decided to do a blood film review. They reported red cell anisocytosis, polychromasia, nuclear red blood cells, schistocytes, thrombocytopenia, and urgently referred the film to the SPR. Similarly, the hematology SPR reviewed the film urgently in agreement with the red cell anisocytosis, polychromasia, Burr cells, 8 fragments per high power field, genuine thrombocytopenia, and they were querying infection or DIC. I will now launch the next poll. This, I think, will need to draw on information that Matt and Deepak have already spoken about previously. Would you need to exclude TTP in this case? Okay. So there's 100 responses for that one. So this is in this case, TTP and ADAMS13 activity was sent to exclude. It was sent to UCLH, whereas Deepak said we use the FRET methodology, which is the gold standard for TTP diagnosis. We then reported the result as 66.2 international units per deciliter. However, for some reason, a sample was also sent to another lab who performed ADAMS13 activity on the AccuStar platform, and this led to a discrepancy in results. The ADAMS13 activity on the AccuStar reported a result of 4 international units per deciliter, therefore indicating TTP. So again, I will launch another poll, and I would ask you, at this point, do you think, given all the information presented and what Matt and Deepak have previously discussed, do you think that this is a TTP case? So we're nearly at 100 responses for that one. So given the discrepant result, obviously an urgent sample was then referred back to UCLH for FRET methodology. And this gave an ADAMS13 activity result of 70 international units per deciliter, therefore excluding TTP. It was later determined that this patient actually had HELLP syndrome, which HELLP is hemolysis, elevated liver enzyme, and low platelet count, and is a rare pregnancy complication which Matt referred to previously, all of which this patient presented with, but TTP needed to be excluded to ensure correct treatment for the patient and to ensure a positive outcome. Thank you for your time and participation.
Thanks, Sabina. Okay, shall we open the floor to questions? If anyone's got any questions, feel free to raise your hand or post in the chat. And if you raise your hand, I'll unmute you so that you can ask your question, or feel free to post in the chat. Okay, so we've got a couple of questions coming through. So the first one is, what's the reason for the discrepant result in the last case identified?
Oh, I can take that. I think so. This is the one that we talked about with the chemiluminescence methods being falsely low in query sepsis type conditions. Now, often the manufacturer is aware of it, and they're working on a solution to fix it. It is complicated, but in circumstances, the FRET method or an alternative method is the only solution for this scenario.
Thanks, Deepak. We've got a couple of questions regarding the sample types used in the testing. So you highlighted in a couple of situations where serum has more advantages. So why is this not the preferred sample type?
Well, ADAMS13 can be inhibited by thrombin and plasmin, etc. And the citrate sample is usually the gold standard for all coagulation testing. So it goes hand in hand to have citrate sample as the sample to go by. But the serum sample is a great alternative if you are suspecting that your sample's compromised for whatever reason. So I think it should be included in local protocols. It's unfortunately not listed in a lot of the manufacturers' kit inserts, so officially you can't use it. You have to internally verify it, but you'll find that it is a very useful sample type in a lot of situations.
Thank you. We've got a couple of questions regarding the clinical side of things as well. So these will be for Matthew. Because the conditions discussed are life-threatening and rare, what is the turnover for testing? And if it is rare, why is there a whole team dedicated to this? What's the approximate ratio of population who have this per year?
So estimated incidence is around 2 to 6 cases per million. The reason that the disease is rare, but we get in London and the southeast around 1 case of confirmed TTP a week. So that requires a team to administer that care. I saw a question about follow-up and testing. So turnaround time for samples. So what I would say is the suspected TTP needs to be treated as a medical emergency. So we shouldn't be waiting for the ADAMS-13 results. So what should be happening is the routine tests such as the full blood count, the LDH, the troponin, the retics should be triggering a blood film. That should then be triggering a call to the local hematologist, and then a referral to a specialist centre should be happening. So the turnaround for the ADAMS-13 testing isn't the rate limiting step here. There should be being a urgent referral to a specialist centre, but in order for that to happen, there needs to be the review of the blood film and the raising of the question of does the person have TTP. There's another question about follow-up for patients. So we recommend all patients with confirmed TTP are followed up long-term. Usually patients don't require long-term immunosuppression. Usually after a course of rituximab, they would go into a remission, meaning their ADAMS-13 is normal. And we would monitor patients for that in the long term, with around 30 to 50% of people having a fall requiring subsequent elective rituximab as a defined course, but not long-term.
Thank you. We've got a couple more questions in the chat, but unfortunately we are 2 minutes over the allocated time. So what we can do is I can record the questions and we will email out answers to you at a later time. So closing the meeting, thank you to our presenters for the enjoyable and informative presentation. And thank you to the 180 or so of you that took your time out to attend this session as well. The team have organized a short quiz for you to test your understanding. So you can either scan the QR code on the right-hand side, and I'll also post a link in the chat now for you to access that quiz. Answers to the quiz will be sent alongside the certificates of attendance in the next few weeks. Once again, thank you very much. Lots of thank yous from the attendees in the chat. Thanks, Dr. Matthew Stubbs, Deepak, and Sabina. Have a lovely day, everyone. Goodbye.
Thank you all for joining. Bye.